Hi, it's Scott Bradley. I'm here discussing a clinical case about an acute headache emergency. We've gone through some of the lectures, and now we're going to discuss a specific clinical case from start to finish, ask some pointed questions, and later we'll get an expert in to kind of discuss a little bit of the evaluation and management of this patient. So our clinical case begins in the emergency department. We have a 23-year-old previously healthy male presenting to the emergency department with progressive severe headache over the past 2 days. Headache is the worst headache of his life, associated with fatigue, photophobia, some chills, body aches, but he doesn't report a specific stiff neck. The pain is on the right side of his head. It starts behind the eye and radiates throughout the head and neck. And again, the patient is previously healthy without any known past medical history. So the medical student in this clip will evaluate the patient, has evaluated the patient, and will be presenting it to the attending.
I have a 23-year-old law student with 2 days of right periorbital throbbing headache associated with nausea and photophobia. No fever, no stiff neck, no history of migraines, but this one seems classic. I'm thinking a 6 of Imitrex sub-Q.
Yep, sounds good.
So this initial presentation of a 23-year-old previously healthy male with this headache, what parts of this history do you think are concerning for possible dangerous emergencies? Again, previously healthy, no history of headaches, no history of any other dangerous medical conditions that you know, no current treatments. So what sort of red flags would you take out of this case from just the history alone? Another question is that the medical student is assuming that this patient who is presenting with a migraine, certainly with the nausea and photophobia, certainly a possibility. Do you think it's an appropriate treatment to go to empiric migraine treatment medications, or does this patient deserve a more aggressive workup or evaluation?
What's going on?
I was just coming to get you.
What's his name?
Paul Sobricki.
How you feeling, Paul?
My wife doesn't like the diner either, and I none of them
He suddenly
listen.
started babbling.
Yeah, he's puking. None of them listen.
He's altered. Why didn't you come and get me?
I was on my way.
I'll be there. You can meet me there.
All right, so during his stay in the emergency department, the patient apparently had a decline in his overall level of consciousness. He's now confused, he's not following commands. It makes us question the initial evaluation if the patient really was as healthy and normal as he initially presented. At this time, we note the vital signs as the following. Heart rate is elevated at 120 beats per minute. Respiratory rate is elevated. Blood pressure appears normal. Oxygen saturation is normal. The temperature is actually what we consider a low-grade fever, but technically a fever. So this patient is not as straightforward as we initially kind of assumed. So what parts of this patient's physical examination, now that you've seen him, are concerned, and what other things are you going to be looking for?
Don't tell them. I don't.
This could be
I don't want you to
encephalitis
tell
or
them.
meningitis. Damn it, Lucy, you should have told me this when you presented him.
He seemed fine, and I was coming to get you.
All right, Malik, give him 2 of Ativan IV push. Lucy,
No, I
check his
need more help.
electrolytes, calcium, thyroid panel, and tox screen. I'm gonna go get an LP kit.
All right, so now you see that the patient has declined, and the attending is now involved in the case, and he's rattled off a series of orders. But I'd like to take it back just a moment to ask the question: how would you initially stabilize this patient? So first steps in the emergency medicine approach. What would you check on your initial evaluation after you determine that the patient appears sick? And the second, what would be your differential diagnosis for a young, otherwise healthy male, or presumably otherwise healthy male, that comes in with altered mental status and a fever? The doctor ordered a series of tests, which included electrolytes, calcium, thyroid test, toxicology, and he's going to go for getting an LP kit. Is there any other additional tests you might order if this were a patient under your care, given that this patient is with headache, altered, and seems to be febrile?
Ativan, put him right out.
Okay, drop the lidocaine.
1 and 4 for cell count. Protein and glucose in 2, and gram stain and culture in 3.
You got it.
So lumbar puncture was performed successfully, and as you heard from the clip, we divide the tests into cell count, protein, glucose, and then gram stain and culture. And we are fortunate enough to have the results come back fairly quickly. As you can see, these are all abnormal, and they're abnormal in the following ways. The cell count is quite elevated. It's over 1,000 cells per microliter, when normally it should be less than 5. Often you'll get a differential with these, looking for white blood cells versus red blood cells. And I can tell you that this is going to be a neutrophil predominant cell count. Protein is quite elevated as well. Glucose is noted to be low, and the gram stain shows a few gram-positive cocci in pairs, which pretty much nails our diagnosis. So you have LP results now. You've gone from the beginning to the end. The next question, of course, is with these results, what are your next steps? What are your next treatments? What other things do you have to consider in treating and managing this patient? Where should this patient go? Is it okay to send the patient home? Should they go to the ICU? What consults, if any, should be called? And basically what the next steps are. So try to think of the next management treatment options and disposition for this patient. And we'll get back to you when we have an expert to talk to us about these questions.